Tonight I'll be presenting a article about differential diagnosis of lesions of variable radiopacity in the jaws. To start, we're going to address a step-by-step guide that emphasizes the importance of methodical approach when producing a differential diagnosis. As a first step, for describing any radiopacity, we will describe a site or anatomical position. So that's the opacity if it's actually within the bone or if it's within the surrounding soft tissue and is superimposed on the bone. To localize the opacity, usually two radiographs are required, ideally at right angles to one another. Also, size, shape, outline, or periphery are addressed in the first step, as well as its relative radiodensity, effects on adjacent surrounding structures, and time present, obviously, if known. The second step in the differential diagnosis is deciding whether this radiopacity is actually a normal anatomical feature. So in the mandible, it can be an area of dense bone, sometimes referred to as dense bone island. A bony prominence such as the external oblique ridge, mylohyoid line, or genial tubercle. Another overlying bone such as the hyoid bone, or in the maxilla, it can be another overlying bone such as the zygoma or anterior nasal spine, or another overlying structure such as nasal cartilage or soft palate. Alternatively, it can be artifactual. That means they can be real or ghost earring shadows, fixer solution splashes, objects or scratches on intensifying screens. And thirdly, they can be pathological, which we're going to focus on here the most. So if it's pathological, we have to decide within which of the following major categories it should be placed. So whether it's abnormalities of the teeth, conditions affecting the bone, superimposed soft tissue calcifications, or foreign bodies. There we go. So as we said, we have abnormalities of teeth, which can be unruptured or misplaced teeth, including supernumeraries, odontomes, which, as we know, can be compound or complex, root remnants, hypercementoses. Also, there's radiopacity affecting the bone itself. They can be developmental, like exostoses, inflammatory, whether it's chronic infection or osteomyelitis, like sequestras. Tumors, there's calcifying epithelial odontogenic tumors, or odontogenic like amyloblastic fibroodentoma, adenomatoid odontogenic tumor, calcifying odontogenic cyst, which is classified amongst tumors, and odontomes, which can be compound and complex, as we said. Non-odontogenic ones can be benign, as osteomas and chondromas, malignant as osteosarcomas, and there's subdivisions of that as well. Fibrous osseous lesions can also be fibrous dysplasia, periapical cementosis dysplasia, focal cementosis dysplasia, fluoride cementosis dysplasia, familial gigantiform cementoma, benign cementoblastoma, cementosifying fibroma. Others are included as Paget disease of bone and osteopetrosis. Concerning superimposed soft tissue calcifications, which we can see as radiopacities, there can be salivary calculi, calcified lymph nodes, calcified tonsils, phlebolyths, calcified acne scars, and also we have foreign bodies that can be either intrabony or within the soft tissue, or on or overlying the skin. Now, let's start with the abnormal radiopacities of teeth. So we said unruptured or misplaced teeth, including supernumeraries. Radiopacities caused by these unruptured or misplaced teeth are readily identified as such radiographically by their characteristic shape and radiodensities. We can see wisdom teeth impacted on the picture or radiograph numbered A, or an impacted canine on radiograph B. Next, we have odontomes. Odontomes can be either compound or complex. They are basically dental developmental anomalies. Compound odontome, which we can see in the picture above, radiograph above, is made up of several small teeth like denticles. The miniature tooth shapes are dental tissue radiodensity with a surrounding radiolucent line and are easily identified radiographically, whereas the bottom radiograph shows complex odontome, and it's made basically of irregular confused mass of dental tissues bearing no resemblance in shape to a tooth. Basically, the enamel contact provides the dense radiopacity suggestive of dental tissue, and again the mass is surrounded by a radiolucent line. Next, we have on the left is a radiograph of root remnants. So basically, deciduous and permanent root remnants remaining in the alveolar bone following attempted extractions are common. The site, shape, and density make radiographic identifications relatively simple. Additional diagnostic radiographs include the surrounding radiolucent line of the periodontal ligament shadow, and sometimes evidence of a root canal treatment, as we can see it on the radiograph on the left. We also have cementoses. So hypercementoses that we see on the radiographs to the right basically present formation of excessive amounts of cementum, usually around the apical portion of the root. Cause is unknown, but it is sometimes seen in Paget's disease of bone and is typically craggy and irregular. Diagnostically, hypercementosis is not a problem. The resultant opacity being part of the tooth root and producing an alteration to the root outline. We can see it with on the teeth with the arrows on the x-rays. All right, we'll continue on to the conditions of variable opacity affecting bone. First, we have developmental conditions such as exostoses, including tori. So basically, mandibular and palatal tori. They consist primarily of compact bone and produce an ill-defined radiopacity when superimposed over the bulk of the alveolar bone. Usually, two views are required to establish the exact site, which we can see in this slide. Basically, we have a slide from above and from the side confirming that this is a mandibular tori. We also have palatinal tori or torus palatinus, which can be either side of the midline towards the posterior part of the hard palate. Next, we have tumors. A calcifying epithelial odontogenic tumor or a Pindborg tumor usually arises at ages 30 to 50-year-old adults. Frequency is very rare. It's shown on molars and premolars of the mandible, and the size is about 1 to 3 centimeters in diameter. The shape is monolocular or multilocular, usually round, often associated with an unerupted tooth. The outline of this radiopacity is variable in definition, frequently scalloped, and it also has a variable cortication. The radiodensity is radiolucent basically in early stages, then numerous scattered radiopacities usually become evident within the lesion, often most prominent around the crown of any associated unerupted tooth. This appearance is sometimes described as driven snow. We can see an example of this in this slide. The effects it has, it basically displaces adjacent teeth sometimes and sometimes resorbs. Expansion of the cortical bone is also present. Next we have on the left here Amyloblastic Fibroodentoma. These rare monolocular or multilocular odontogenic tumors resemble closely to Amyloblastic Fibromas, which we've talked about, and also affect children. However, they usually contain enamel or dentine, either as multiple small opacities or as a solid mass. So basically, and this is a oblique lateral showing a large expansive amyloblastic fibroodentoma in a 5-year-old. The internal calcification is comparable to tooth tissue, and histopathologically it's been confirmed that with the presence of enamel and dentine. On the right we have Adenomatoid Odentogenic tumor. Usually occurs in late teens or young adults. It's very rare. The site is usually anterior maxilla, so in the region of incisors or canines, which we can see on the rightmost X-ray. The size is usually 1 to 3 centimeters in diameter. It is monolocular, round or oval, often surrounded an entire unerupted tooth. The outline is smooth and well-defined and well-corticated, so not scalloped. Radiodensity is initially radiolucent and has sometimes small opacities like snowflakes within the central radiolucency, may be seen peripherally as the lesion matures. It can also displace adjacent teeth, but rarely resorbs them. Its associated tooth is often unerupted, and it can show some buccal or palatal expansion. Next we have calcifying odontogenic cyst or Gorling cyst. It has also been classified as an odontogenic tumor. So it presents typically as radiolucency resembling other odontogenic cysts, but as it develops, a variable amount of calcified material becomes evident scattered throughout the radiolucency. The opacities can range from small flecks to large masses. Basically, the patient age is variable, but usually adults over 40 years old can present with this. The frequency is very rare, and it usually occurs in the mandible, anterior or premolar region, occasionally associated with an odontome or unerupted tooth. The size is usually very small, again, 1 to 3 centimeters in diameter. The shape is also variable, but most often is monolocular. It is smooth and well-defined and often corticated. Initially, the radiodensity is not evident, again, radiolucent, and in more advanced stages contains a variable amount of calcified radiopaque material of tooth-like density. It can also displace adjacent teeth or resorb, and can show a bony expansion. So we can see a well-defined calcified odontogenic cyst in the radiograph A. It's present in the mandible with an obvious area in the center itself of internal calcification. Next we have osteomas. Osteomas of the jaw may be located in the medullary bone and thus called endosteal osteomas, or maybe around the bone or on the surface as a pedunculated mass, thus called periosteal osteomas. They're usually detected in young adults and are typically asymptomatic. Solitary lesions, multiple jaw osteomas are features of a rare inherited condition, Gardner's syndrome. Osteomas can either be compact or cancellous. Compact osteomas consist of dense lamellae of bone, including the so-called ivory osteoma, occasionally seen in the frontal sinus. Cancellous bone consists of trabeculae of bone, which we can see in the radiograph C. The trabeculations are pretty evident. Both tumors are uncommon, basically. The type of bone making up the tumor determines the degree and radiopacity. It is basically a benign tumor, contrary to the next tumor, which is an osteosarcoma. So osteosarcomas are basically rare, rapidly destructive malignant tumors. From a radiological viewpoint, there are 3 main types. So these are the divisions that we have: osteolytic osteosarcomas, osteosclerotic osteosarcomas, and a mix between osteolytic and osteosclerotic. The osteolytic ones have no neoplastic bone formation, whereas osteosclerotic, you guessed it, they have neoplastic osteoid and bone formation. So in early formation, the osteosarcomas are non-specific, poorly defined radiolucent areas around 1 or more tooth, and widening of the periodontal ligament space can happen. Now, for an osteolytic lesion, as it matures, it becomes monolocular and with the ragged areas of radiolucency. It looks basically moth-eaten, and there's also spiking resorptions with loosening of associated teeth. For osteosclerotic and mixed lesions, there is a very characteristic sunburst or sunray appearance that we can see on radiograph B. It is nonetheless a poorly defined radiolucent area. Variable internal radiopacity with obliteration of normal trabecular pattern. There's also distortion of the alveolar ridge present. We can see the distortion on the X-ray under letter D. Next, we have fibrocementous osseous lesions. So we have several. These conditions are defined as skeletal disorders in which bone is replaced by fibrous tissue, which in turn is replaced by mineralized tissue, bone and or cementum, to a varying degree as the lesion ages. Although these lesions are radiolucent in their early stages, they're commonly seen clinically as variably radiopaque lesions. Now, here we have a fibrous dysplasia, monostatic. It's considered to represent a developmental tumor-like lesion. Most cases, around 80%, are monostatic. The general radiological feature of fibrous dysplasia are basically patients of 10 to 20 years. Site is usually the maxilla, so posteriorly in the maxilla, and the mandible doesn't really have any frequency of this tumor. Size is variable and difficult to define. Shape is usually round. It's poorly defined with the margins merging imperceptibly with adjacent normal bone. And it's not corticated, so it's ill-defined, basically. The initial radiodensity is not as prominent. It's basically radiolucent in the start and gradually becomes more opaque, producing this typical ground glass orange peel or fingerprint appearance, resulting from superimposition of many fine, poorly calcified bone trabeculae arranged in a disorganized fashion. And it becomes more and more opaque as it matures, per se. The adjacent teeth sometimes can be displaced, but rarely resorbed. There's also buccal and lingual alveolar expansion and encroachment or obliteration of the antrum. Involvement of the adjacent bones, including the base of the skull, is something that is also possible to happen. Next, we have periapical cementosious dysplasia. Usually happens to middle-aged adults. Statistically, it is shown that Black women have more predisposition to periapical cementosious dysplasia. However, it is very rare, the frequency. Site, as the name suggests, is apical or periapical of several lower incisor teeth. So the lower incisors are the ones that are affected the most. Small, usually up to 5 to 6 millimeters in diameter is their size. They're round and monolocular, and they often appear on more teeth. So it's basically a multiple osseous dysplasia. In early stages, it starts as a radiolucent lesion, but then as it matures, the opacity increases and becomes densely opaque in its later stage of life. The adjacent teeth do not get displaced, they do not get resorbed. Teeth are typically vital with intact periodontal ligament space, but the lamina dura may be discontinuous. And also, there's no expansion of the jaw. We have also focal cementoosseous dysplasia, which is seen on the right radiograph. It is usually a solitary fibrocementosseous lesion occupies a portion of the spectrum between the periapical and fluoride cementosis dysplasia. It usually occurs in adults between 40 and 50 years. This is statistically shown to be more prone with white women. Frequency is, however, uncommon, not as rare as the periapical cementosis dysplasia, and it can appear at any area of the jaws, but mainly the posterior mandible is where it's presented, with a size less than a 1.5 diameters, being round and monolocular. In early stages, it starts off radiolucent and matures, becoming more and more radiopaque. And in the later stages, it's off, as it becomes fully radiopaque, it also has a thin line of radiolucency around it. Similar to the periapical cementosis dysplasia, the focal one also does not displace nor resorb adjacent teeth, and they remain vital without expansion of the jaw. Next, we have fluoride cementosis dysplasia, or gigantiform cementoma. It usually appears in middle-aged adults. It's very rare. The site is widespread, so often in all four quadrants, whether they're dentulous and edentulous, but associated with the apices of teeth if they're present. They're variable in size, usually around 2 to 3 centimeters. There's different shapes, but usually it's round, and frequently they can coalesce, so within the quadrants. They're smooth but lobular, moderately well-defined but irregular. So the radiodensity, again, commences in the early stages with a radiolucent presentation. And then the intermediate stage presents multiple radiolucencies with gradual increased patchy internal opacities. And then in the later stages, multiple irregular dense radiopacities within individual lesions, sometimes surrounded by a thin radiolucent line. The effects which are characteristic with the cementosis dysplasia is that, again, they do not displace nor resorb adjacent teeth, which remain vital. Occasionally, it may cause expansion or enlargement of the affected jaw, and it can be associated with low-grade sclerosing osteomyelitis. We also have a familial gigantiform cementoma. It is a very rare familial fibrous cementoma. It is inherent as an autosomal dominant condition and confined almost exclusively to young, so 10 to 20-year-old white people. The lesions characteristically show relatively rapid growth, causing marked facial deformity. Next, we have a benign cementoblastoma, also called true cementoma. It is classified as an odontogenic tumor, but because of the similar radiographic appearance to the fibrocementosis lesion, it is sometimes also included within the cementomas. So it usually occurs in adults under 25 years. It's very rare. The site is always the apex of mandibular molars or premolars. Size is variable, but it can grow up to 2 to 3 centimeters in diameter. It's round or irregular in shape, sometimes described as resembling a golf ball, and it is always attached to a tooth root. Well defined, it is radiopaque, but often surrounded by a thin radiolucent line, which increases that definition, basically, and often surrounded by a diffuse area of sclerotic bone around that. The effects that it has on surrounding tissue is it can be attached to the tooth root, which is usually obscured as a result of resorption and fusion to the tooth. If it's large, it may cause localized expansion of the cortical plates. Next, we have Cemento Ossifying Fibroma. It is the embracing term to describe this demarcated and occasionally encapsulated odontogenic neoplasm. It was previously known as ossifying fibroma or cementifying fibroma. The age is quite wide, so from adolescents to middle-aged adults, particularly women, present with cementosifying fibroma. The frequency is rare, and it can be localized in premolar or molar region of the mandible. Size is variable, but it may grow to several centimeters in diameter and cause facial asymmetry. It is round in shape, as is presented in the X-ray marked A, and monolocular. Outline is smooth and well-defined. When opaque, usually surrounded by a thin encapsulated radiolucent line, usually corticated and circumscribed. Its radiodensity starts with being very radiolucent, and as it progresses, it gradually increases with radiopaque calcified patches. In the later stages, the radiopaque zones coalesce to form a densely radiopaque mass with or without a radiolucent periphery. The effects on the adjacent tissue, so on the teeth are often displaced and occasionally resorbed, and the expansion of the surrounding bone in all dimensions often is demonstrated as a downward bowing of the mandibular lower cortex. Next, we have soft tissue calcifications or superimposed soft tissue calcifications. These are radiopacities that are usually in salivary glands or lymph nodes. Here we have a salivary gland calculi. Submandibular gland calculi are often radiopaque, and they develop within the main duct or in the gland itself. Those in the main duct are often superimposed on the outer bone, producing an opacity apparent within the bone. Stones in the gland present usually below the lower border of the mandible. We can see the salivary calculi from two different angles on this X-ray. We also have calcified lymph nodes, which we can see here. So especially on in the lower left quadrant. The calcification of lymph nodes is relatively common following chronic infections like tuberculosis. It's basically kind of a formation of scar tissue. The nodes that are usually involved that we can notice are the submandibular or cervical chain, single or multiple. They are usually behind or below the angle of the mandible, and appear as irregular, heterogeneous, opaque mass resembling a mass of coral, like a little coral reef, I guess. We also have calcified tonsils. Calcification of the tonsils is sometimes seen as an incidental finding on dental panoramic tomographs, and especially in elderly patients is present. The area of calcification appears as a small, irregular, opaque mass overlying the superior aspect of the ramus of the mandible, and they're often bilateral. On the right radiograph, we can see phlebolyths. Phlebolyths are calcifications of thrombi within the veins and are occasionally seen in hemangiomas. If the radiograph shows the calcified blood vessels end on, the phlebolyths have a characteristic target appearance. Radiopaque around the periphery and radiolucent in the center. And it's also worth noting there's, we don't have an X-ray for this, but there's calcified acne scars. So calcifications can develop in scars of severe acne, and they produce multiple small radiopacities in the area involved. If the acne calcification is suspected radiographically, the diagnosis can be confirmed by clinical examination. Lastly, we have foreign bodies. A variety of foreign bodies can produce radiopacities. The appearance depends obviously on the nature of the foreign body, its density, and its location. We can see radiopacities of amalgam debris in radiograph A and B, as well as a root canal sealant that is in the inferior dental canal in radiograph C. And lastly, I'm just going to leave this table of summary of the main lesions. There was quite a bit, and this is a table of the main lesions of variable radiodensities and that can develop internal radiopaque calcifications. Thank you for listening.
Wow, thank you very much, Dr. Milos. That's very, very nice. If you check your WhatsApp, I'm sending you the acne picture. Maybe you can share it with the rest right now.
I'm okay. I'm gonna try to do that. The problem is I'm on my laptop.
So random, yeah. So random enough that I actually do have an X-ray of an osteoma cutis. You know.
Oh yeah. I know. I just see it. Yeah. Very interesting.
Okay. Anyways, thank you very much for this. I think we are probably. Do you have some? I think I believe Fatima asked you to do some questions for us for the sake of the credit.
Yes. Unfortunately, I received that request today on my way from work. So
it's okay.
Yeah.
It's okay. No problem. So you know what? Why don't we have a battle of schools today? Today we are having 4 people from 4 different schools. So why don't we see who's going to win, right? Actually, you know, not mentioning NYU as well, since Shihab is from NYU, so why not? And Talib is actually from California, and Usman is from Ireland. No, we have actually more than that. So why don't we do this? You've mentioned the sunburst appearance, right?
In the osteosclerosis, yeah, in the osteosarcoma.
Yes. Do you have an explanation to us why that happens?
It's basically of what I know is the osteosclerotic reaction to the carcinoma. It's basically compared to the osteolytic one that doesn't present the sunburn. The osteosclerotic one presents it as a reaction of the body, I guess.
I don't know if Rose, are you online?
Yes, I'm here.
Right, Rose, what do you think? What are your thoughts on this?
I'm not sure. I agree with him, actually.
Okay.
But I don't know. Yeah.
Right. Steve, what does Western Ontario say? Steve is muted. He just chose to be muted. That's fine. All right, let's see. Well, personally, the way that I think about it is this, is that whenever you have an aggressive lesion and, you know, the periosteum, it grows so fast and the bone grows so fast that it does find it very difficult for it to act a new periosteum layer, right? So this is exactly what's happening. And that's the appearance of sunray appearance that you have. It's just basically a very fast periosteal reaction to the lesion. And this sunburst appearance is aggressiveness appearance. So it just like makes, just like the lesion has developed really, really very fast. Is there any clinical applications to this lecture? So if we talk about fibroosseous lesions, is there any clinical applications for the fibroosseous lesions, for example? Why do we really need to care about fibroosseous lesions? Maybe Dr. Amin? Since I'm going to give you a hint that you're actually doing the implant course, so maybe you get a hint why the fibroosseous lesions are very important for us to identify.
I would like a hint because of cancer detection.
What cancer has got to do with it? I mean, when you have a fibroosseous lesions, you really, you remember all the theories about bone, and if you have a fibrous lesion, do you think you're going to have an impaired healing if you do an extraction?
Yes.
All right, good. And do you think your implant is going to osteointegrate?
No, it's gonna.
Right, right. Do you run the risk of maybe a jaw fracture? Because the whole idea is soft. If you're taking up a wisdom tooth and you have applied up your elevator in a wrong position?
Yes.
Yes, absolutely. Absolutely. So it's very important for us to identify that. I mean, if you're trying to think that you have an extraction and you think this extraction is very easy and the area doesn't heal, right? Suspect this, suspect that you have a fibroosseous lesions. In the same scenario as well, when we talk about tuberosity, we really need to probably remember that the mucosa among the tuberosity will be extremely very thin. A lot of the times if you are doing an extraction or something like that, and the patient is taken up some of the anti-resorbative drugs or things like that, a lot of the times you'll probably end up seeing that on those tuberosity, because one of the theories is soft tissue theory. And if the mucosa is really very thin, you're definitely going to end up with this. I don't know, Dr. Sally, do you want to add anything to this? I guess not. Okay. I guess I have one question from last time's lecture, right? That is gonna go to Usman. Usman, can you please tell me what in amyloblastomas, let's just go to amyloblastomas. I'm sure that it was discussed last week, a couple of weeks ago. And histopathologically, you're always going to look under the microscope for something called Vickers-Gorlin criteria. Vickers-Gorlin criteria. Do you remember this?
Unfortunately, I didn't attend last week's lecture.
Oh my God. See what happens when you don't? You miss the Vickers-Gorlin criteria. Okay. You know who was attending last week's? Amin was attending last week. Last time. Amin, did you attend 2 weeks ago?
Unfortunately, no, I did
Oh
not.
my God. You miss that. Okay. Any takers about the Vickers-Gorlin criteria? Gorlin is the man, right? So if you remember Gorlin, you're going to remember Gortis-Gorlin syndrome. You're going to remember a lot of Gorlins, right? Gorlin is the man. But Vickers-Gorlin criteria, histologically, if you look into ameloblastoma, you're going to have in the microscope, you're going to have a tall columnar basal layer. You're going to have a hyperchromatism of the basal cell nuclei. You are going to have a polarization of the basal cell nuclei away from the basal membrane. So you basically, your basal cell that is elongated and become columnar, you're going to see that it becomes hyperchromatic. That means it absorbs up the dye too much, and then the actually nuclei will become polarized away from the basal membrane, and you will have an extension of the basal cells. They call that cytoplasmic vacuolization of the basal cells. I mean, it's a geeky piece of information, but I do believe that it's a common exam questions. And for some of you who are new to the province of Ontario, dentistry, I believe every 3 or 4 years you have to do a test. I'm not quite sure. Maybe Dr. Sally knows about this more than me. And you know what? I probably would put that. I said I would definitely put which one. All of these are criterias in the that you might see under the microscope for an ameloblastoma, except, and I will put up those, and I will just throw up a random one like, I'll probably put up a well-centered nuclear or something like that. And that's the one that you're probably going to have to pick. But anyways, apart from that, I want to thank you for being here. I'm not going to keep talking to you because it is right now 10:18, and I believe everybody's tired after listening to this. I want to thank Dr. Milos. I want to pick on someone. So Dr. Sally, who do you want to pick on? If you're listening, if you're feeding the baby, give me thumbs up and I will actually choose one. If not, you pick one. So you know what? I'm going to pick one. How about if we pick on one of my favorites, Rose? Rose, I'm going to pick on you. So after 2 weeks, you're going to present. Is that okay?
Yes, that's okay. What am I presenting exactly?
How about if we do something that you've read before with me? How about if we read Dean Haas Local Anesthesia? What do you think?
Okay,
Is that
sure.
okay? That's actually
Yep.
a good one. I will forward the article to the group. Again, it's one of the RCDSO recommended articles to read. It has a wealth of information, and hopefully Rose, and not hopefully, I'm sure that Rose will do a great job next week doing that presentation. Apart from that, any concerns, any questions to Dr. Milos? Now is the time. I guess there is no questions. Everybody knows their, I guess everybody knows their radiopaque lesions, right? Everybody knows everything about radiopaque lesions. So that is the case. Be prepared.
It was such a good presentation, I gotta say.
I know. It was one of the best ones that I actually seen. Thank you very much for putting it in such a. So can you all seize that? They actually look like donuts and they're called osteomocuties, right? And if you think about it, those are not the acnes. This is the makeup on the acnes superimposing. So it's just an artifact, if you really think about it, foreign material more than anything else, right? So acnes act as holes, and the holes, the makeup appearance, the makeup goes into them. And then when you take a radiograph, this is how it appears. Does that satisfy you, George? I know how random that is. Anyways, thank you very much for everything. I want to thank everybody. As always, please, if you're not registered, register so Fatima can send you by email your continuing education credits.
Dr. Hassan,
Yes.
Dr. George asked you a question.
Oh my God, where is the question? Can you say the question? Because I don't see it.
Sorry, I'll read it for you.
Do you have a photo?
He says, do you have the photo? How would you
How do you-
treat this or discuss with the patient?
You don't treat it. It's just basically it's an artifact. So basically, if you have an acne, if you think about acne defects in the face and the skin, when you put a makeup, it will appear like that. So you just wash your face, clean your face. It will not appear on the radiograph. So technically, if you want to really be very specific, you see the treatment of the acne is a treatment to this, but it's not something that you really treat, right? This is just an incidental finding in a radiograph due to the fact that the patient has acne and wears a makeup. That's what it is. I hope that helps. Fine, Dr. Usman. Yes, we will treat the 4-4.